Good morning, everyone. I'm going to talk about U-tool, a novel method for measuring corneal diameter in infants screened for congenital glaucoma. How should I move it? Excuse me. It's not there. As is known, corneal enlargement is the common feature of congenital glaucoma. It is an important indicator for diagnosis and monitoring the progression of the disease. Castor caliper is being routinely used for measuring corneal diameter, but it needs examination and anesthesia or sedation. We devised a simple U-shaped tool using 3 shimmer strip or a printable ruler to measure the corneal diameter in settings where ophthalmic caliper is not available or UA is not feasible. And infants presenting to congenital glaucoma clinic, posters for UA were recruited. Before UA, corneal diameter were measured using U-tool. During UA, it was measured using Castor caliper, and both the corneal diameters were compared. In cooperative children, U-tool was just placed above the orbital rim. If child is not cooperative, when the child was asleep, the eyelids were gently retracted by the attendant, and U-tool was placed. Then photo was taken with a smartphone. Care must be taken that the U-tool and the smartphone should be parallel to the eye so as to avoid the parallax error. Then see here you can see the smartphone and U-tool is parallel to right. Then using the image editing software, we draw a rectangular line extending through the limbus, and the readings in the U-tool is noted. Here you can see the readings are noted in various children. As we do not place the U-tool on the corneal limbus to measure the corneal diameter, a correction factor must be applied for the magnification caused due to distance. The distance from the corneal limbus to the U-tool was approximately 16 mm, and the correction factor at 16 mm distance was approximately 1.15 mm. The corneal diameter was calculated by multiplying the U-tool reading with the correction factor. Most of the patients were having primary congenital glaucoma. This shows that the corneal diameter measured with the Castor caliper and U-tool were almost similar. By chance, if we didn't apply the correction factor, the diameter using the U-tool was 1.5 mm lesser compared to that of Castor caliper diameter. The difference between the corneal diameter using two techniques was minus 0.1 mm with a narrow bland alignment plot, 95% limits of agreement. It had a good correlation. Limitation include measurement error could occur if U-tool or phone is not placed parallel while taking the photographs. Sedatives or anesthesia might be needed in a non-cooperative children. 18% of the children required sedatives or anesthesia. Stretched limbus in congenital glaucoma could also cause variation in measurement of corneal diameter by different observers. To conclude, this is a novel innovation, provides a no-touch technique of measuring the corneal diameter. Considering a difference of plus or minus 0.5 mm within the acceptable range, 72% of the readings taken with a U-tool were in acceptable range. It provides a corneal diameter measurements in awake or sleeping state with or without use of sedatives or anesthesia in majority of the cases. Hence, it can be used for screening pediatric glaucoma by first contact physician, optometrist, or by ophthalmologist, especially when the UA is delayed. Thank you. Thanks. Thanks.
Thank you, Karthikeyan. I'd like to have the esteemed opinion of Dr. Samar Basak, sir.
Thank you, Karthikeyan. This is wonderful, simple, and very effective for pediatric, age group to measure the corneal diameter. So we usually do sedation or this thing, but this is wonderful and your correlation is good. So I think there is nothing, it is so simple.
Thank you, sir.